Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm one of your co-hosts for the AOMPT podcast. I'm excited to bring to you another great interview. Our guest today is Dr. Caitlin McArthur. Dr. McArthur is an assistant professor at the School of Physiotherapy at Dalhousie University, which is located in Nova Scotia, Canada. Her research focuses on improving the effectiveness of and access to rehabilitation for people living with chronic health conditions across the continuum of care, particularly those involved with home care and living at long-term care facilities. With a passion to improve mobility and quality of life of clinically complex older adults, Dr. McArthur is a lead instructor of the continuing education course BoneFit, hosted by Osteoporosis Canada, which teaches exercise professionals about safe movements, physical activity, and exercise for people with osteoporosis. Dr. McArthur is also an Associate interRAI Fellow, and we'll link to both of these affiliations in the show notes. The article we're going to talk about today is titled, "What Do We Know About Spinal Manual Therapy for People with Osteoporosis? A Narrative Review." You can find this article in Physical Therapy Reviews, Volume 26, Issue 2. As always, we'll link to the publication in the show notes. And with that as our general introduction, let's get to the interview. Dr. McArthur, welcome to the podcast. How are you doing today?
I'm doing very well. Thank you for inviting me to be on the podcast. I'm excited to be here.
Well, we are also excited to have you here, so thank you for joining us. And I'd like to say that I know our audience is going to be grateful to listen to a conversation about this topic. As I pointed out in the introduction, this manuscript was published in Physical Therapy Reviews, and I strongly encourage everyone to check it out because it is just chock full of good information. Speaking of which, let's start off with asking you the question, can you just let our audience know how this research project came into existence?
So this project came into existence through some continuing education that I do. So I teach a continuing education course that's run by Osteoporosis Canada. It's called BoneFit. And this course is for clinicians who work with people with osteoporosis. So it's for physiotherapists, occupational therapists, also other exercise providers like yoga instructors and personal trainers, and basically anyone who's going to be providing some sort of exercise or rehab for people with osteoporosis. And particularly from our clinical attendees, so usually from physiotherapists, the question about manual therapy always comes up. Pretty much every workshop, somebody will ask, if somebody has osteoporosis, should I be doing manual therapy with them? Is it safe? Sometimes I see it's a relative contraindication. Sometimes I see it's an absolute contraindication. What should I do? And as an instructor, I, of course, went to the literature, and really there's no clear answer out there. There was a lot of information to help me answer this question for people. I found the same answer. Sometimes it's absolute, sometimes it's relative. Some people say, yeah, go ahead. Some people say, no, don't ever do it. So that's kind of really what brought it to the forefront. And myself and my co-authors decided to kind of pursue it and try to answer this question for our participants.
I think that's a great way to have the project come into existence. And while not from the same teaching standpoint, I've had a similar experience in the clinic in that it's one of those questions that I get asked all the time by patients. And they ask it in a range of ways. One of my favorites is when the patient says, as I'm, pushing on their thoracic spine, their rib cage, their wrist, they'll just ask, have you ever broken a bone while working on a patient? And they're essentially asking this safety question as it pertains to their osteoporosis or something. But anyway, that's part of why I think it's such a great research question. And building off of that, can we dive in to have you explain a little bit about the general statistics surrounding osteoporosis, epidemiologically speaking, what does a clinician need to know about osteoporosis?
Yeah, that's a great question. Osteoporosis is, we often call it the silent thief because a lot of people don't even know they have it. And it kind of really depends where you live in the world. I'm in Canada. In some provinces, you get really good screening for osteoporosis, and in other provinces, you don't get screened at all. And so a lot of people don't even know they have it. So it's really good to kind of remind people of the kind of basic epidemiology of it so that we remember that you might actually be seeing somebody with osteoporosis and they don't even know. So osteoporosis affects 1 in 3 women and 1 in 5 men. Certainly it's associated with age and sex, so it is more common in older women after menopause. That's kind of the highest prevalence. But what's really important to remember is there are many other factors outside of age and sex that may put somebody at risk for developing osteoporosis. We usually call this secondary osteoporosis. So anybody who's undergone cancer treatment, has a systemic inflammatory condition like rheumatoid arthritis or lupus, or any type of malabsorptive disorder is going to be at high risk for having osteoporosis. And that's because of the disease process, but also the medications that they take for these conditions. So if they take prolonged systemic glucocorticoids or any type of steroid, or if they take androgen deprivation therapy, for example, for prostate cancer, then that can increase their risk for osteoporosis. Other risk factors are things like a parental history of either osteoporosis or hip fracture. What's really interesting is, we really didn't start diagnosing osteoporosis until kind of the late 20th century when we started looking at DEXA scans. And so before that, a lot of people probably had osteoporosis, but we didn't necessarily diagnose it. So a history of parental fracture can be really important to ask because their parents might not have known they even had osteoporosis. So I was asked, did your mother break their hip at any point in their life? Because that's really important to know. Other things like lifestyle, so looking at diet. If somebody has had an eating disorder, they are at high risk for osteoporosis. Or if they have a disorder that doesn't allow them to absorb nutrients from their food as well. So things like Crohn's disease, ulcerative colitis, those types of things. Inactivity, smoking, drinking also increase the risk for osteoporosis, as well as having a low body mass index. So if somebody's quite small, they will not have as much weight being put through their bones, and so they're at a higher risk for developing osteoporosis. So as I mentioned, it's really important to kind of have osteoporosis in your spidey sense, I suppose you could say, because many people don't know they have it until they have a fracture. And that's why we call it the silent thief, as I mentioned before. So you may actually be treating people who don't know they have it. The other thing that I've had happen quite frequently in clinic is people are on medication for osteoporosis, but they've confused it with osteoarthritis. And so I ask, do you have osteoporosis? Because they're taking Actonel or other osteoporosis medications, and they tell me they don't have osteoporosis. So they might have been even diagnosed with it and not know they have it. So it's really important to kind of have it on your radar. The last thing I'll mention related to that is many people don't even know they have a spine fracture, which is quite a common fracture associated with osteoporosis. And they can be silent. So they might not have pain. Maybe they've just started losing height, or maybe they had back pain that they associated with something else, like, I was gardening, so of course my back is a little sore. We know that only 2/3 of spine fractures come to clinical attention. So again, just another reason to kind of have osteoporosis on your radar and make sure you're thinking about it clinically.
Very well said, and I like the breadth of the introduction you did to that topic. I think it strongly indicates that we need a very thorough paperwork intake process and then a thorough verbal process during our subjective examination so that we can think broadly and try to consider so many different factors that could potentially, but aren't guaranteed to impact bone health.
Yes, that's very true. It's important to really, take that thorough history and kind of have those things on your radar to make sure that you kind of have the full picture of the person.
Now that we've gone through some of the background information and risk factors, can you dive into the search strategy that you and your colleagues utilized when conducting this research? For example, what databases did you search and what type of timeframes were you looking at in terms of your inclusion criteria?
So we searched PubMed, Embase, and Sport Discus between 1955 and July of 2020. The main reasons why we search these databases is because they capture much of the scientific literature in the area we were interested in, and really the dates were just from database inception to present. So basically, what's been done since these databases have been in existence. Really wanted to synthesize both biomechanical literature and clinical literature because our question kind of centered around, how safe is it to do spinal manual therapy? Basically, what do we know about it? And we knew that in order to answer that question, we needed to know, how much force is produced when we do, for example, a PA mobilization. How much force does it take to fracture a vertebrae? But then if we look at it clinically, have PA mobilizations even been looked at in a clinical trial, and what has been the effect of those PA mobilizations? So because we kind of wanted to gather both biomechanical and clinical literature, we thought these three databases would help us capture the vast majority of the literature.
I really love how broad that search was, especially in terms of the time frame. Of course, there could be relevant research that is relatively older or newer. I think that's a strong suit or a great component of your search strategy. And speaking of that strategy, what type of relevant results did you find when you were done with the search?
In terms of the biomechanical literature, there was very limited literature about the amount of force required to fracture a vertebra, particularly with PA loading. And why we focused on PA loading or posterior anterior loading is because that was, when we looked at the clinical literature, that was the most common type of mobilization that was examined. So in fact, we only found one article that actually looked at this, and they used fresh, frozen, unembalmed cadaveric specimens. The specimens had a BMD or bone mineral density that was indicative of osteoporosis. So they were specimens that had osteoporosis essentially. And we just found this one study. So, it was very limited. There was a fair amount of biomechanical literature about the amount of force that we as clinicians produce when we do PA mobilization. So we found 16 articles there. And these articles used varying grades of PA mobilization. So from grade 1 to grade 4, we particularly didn't look at grade 5 or manipulations. That's kind of a different question that we weren't trying to answer with this paper. And what we found was that there was really wide variation in the forces produced across these varying grades. In the clinical literature, we also had fairly limited evidence about spinal manual therapy for people with osteoporosis. So we ended up with 4 studies. One was a case study, and the other 3 were randomized control trials. And all of these studies included manual therapy as part of a multi-component treatment program. So they didn't look at spinal manual therapy as just, on its own type of treatment, but they looked at it as part of a broader treatment program that included usually postural training and then exercise prescription in resistance and balance training. And then sometimes there would be other components like taping or kind of other factors like that. So generally, we had fairly limited evidence. Probably the biggest amount of evidence or the most amount of evidence we had was in how much force we as clinicians produce in PA loading. But the clinical literature was fairly limited, as well as how much force it takes to actually fracture a vertebrae.
Based on those findings, how likely do you think we are when applying those forces associated with manual therapy? How likely are we to actually cause some sort of spinal fracture in somebody with osteoporosis?
So in the biomechanical literature, what we found with that one study that looked at how much force it takes to fracture a vertebrae with PA loading, they found that with these specimens they had, it took between 206 to 777 newtons to fracture the vertebrae. So they basically took these cadaveric specimens that they had, they put them in a machine and PA loaded them repetitively and measured how much force it takes to fracture. What they found, it ranged from 206 to 777 newtons. They also found that these fractures mainly occurred on the spinous process rather than the body of the vertebrae. And why that's important is because usually when we see fractures with osteoporosis in the spine, they're usually compression fractures on the body of the vertebra rather than the spinous process. So you can see that the fracture process might be a little bit different with PA loading than with kind of normal fracture patterns that would happen kind of as the person's moving around throughout their life. What we then looked at was the amount of force that was produced by clinicians when they are doing PA loading. As I mentioned, they looked at grade 1 to 4, and they really found wide variation in the forces produced. So what we kind of decided after some clinical reasoning around the topic is that the amount of force that is produced when, as clinicians, we are applying PA loading, this kind of safe zone, it seems, is a grade 3 mobilization. And that's because the amount of force produced when we do a grade 3 mobilization is below that threshold of 206 newtons, which was the lowest force required to fracture those vertebrae. So we concluded that if we stayed at grade 3 or less, that should be a somewhat safe zone. Of course, this hasn't necessarily been proven or looked at in a clinical trial, but using deductive reasoning, that seemed like a reasonable conclusion to make. In terms of certainty of how likely we are to not fracture somebody while doing these PA mobilizations of the spine, it's really hard to say because it hasn't really been studied. I think you have to kind of look at the person in a broader light. So have they had a spine fracture before? How did that spine fracture happen? What's their thoracic kyphosis like right now? Are they hyperkyphotic? That might change the positioning of their vertebrae when you're doing PA loading. And all of those things kind of have to come into your decision as to whether you are going to do spinal mobilization or not.
I think that's a great point. And to add a layer onto it, of course, on a regular basis, manual therapists are working on people with osteoporosis. As you even said yourself, oftentimes the patient doesn't know they have it. And if a grade 3 mobilization, which is a common mobilization, were that dangerous, we would start to see all of these bony fractures occurring as a result of manual therapy. And it seems from clinical practice that, in fact, manual therapy is relatively safe. I, for one, have been practicing for 18 years. And to the best of my knowledge, I've never caused any sort of spinal fracture or extremity fracture in a patient with osteoporosis. And yes, of course, we take things into consideration. If the patient appears to have all these risk factors, we're going to be more gentle. And if you're not, that's really a big red flag for a safety concern. I know it's not perfect evidence, but I like how the evidence that you did find matches up well with clinical practice. It's a very good thing to have occurring in our research processes.
Yeah, exactly. It's good when the clinical reasoning and the research reasoning align. I think the points you made are really good. I'll also add that those spine fractures that they saw in the specimens happen in the spinous process, and that is pretty uncommon to have happen with somebody with osteoporosis, that we see these spinous process fractures. So I agree. We're likely treating a lot of people who have osteoporosis, don't even know it, but we don't see a lot of spinous process fractures.
For the next question, I'd like to channel your interviewer because this question comes directly from your manuscript. In the manuscript, you wrote, "What are the effects of interventions that include spinal manual therapy for people with osteoporosis?"
So what we found is, from our clinical articles, is we found improvement in pain, thoracic kyphosis, quality of life, balance, and upper back and arm endurance. as the reported benefits from the articles that we included. The challenging part, as I mentioned before, is that manual therapy was included as part of a multi-component program. So it's really difficult to know exactly what role manual therapy had in improving these outcomes. It's like it was part of an overall benefit rather than, manual therapy was the thing that helped all of these different outcomes. So again, it's kind of looking at it as part of a broader treatment program. So, I would say what we can take from that is that it could be included as part of that multi-component program that includes things like postural training as well as resistance and balance training. And that's where we might see the benefit. It's kind of an additive benefit. Now, our study was a narrative review, so we didn't evaluate the quality of the evidence or, really dig deeply into teasing out those effects. But this is what we saw in terms of the reported benefits.
And of course, a common theme that we see in this type of research is that the available evidence isn't perfectly clear. We almost never have a 100% confident answer to a question, but it appears that spinal manual therapy is not only appropriate, but that when, of course, introduced as part of a larger program, probably has some benefit. And really, that's how we treat all of our patients, or we should be treating all of our patients. We're educating them on anything from pain science and posture to how to exercise at home. I know some of us are even talking about nutrition and all these other components. I talk with my patients about things like smoking cessation and decreasing alcohol consumption. And then, of course, trying to manage all those other medical conditions that we said could be related. So as always, it's hard to tease out the tiny details to give people the best possible care. We are attempting to be and should be as broad as possible in our clinical services.
Exactly. It's a piece of the puzzle. It's part of that multi-component program that has multiple different things involved in it.
And so in the prior answer, you talked about the things that were shown to be statistically significant in terms of spinal manual therapy and osteoporosis. But in addition to that, when you were done with this search, what different variables were shown to not be statistically significant with respect to this topic?
So the ones we found that did not demonstrate a statistically significant change pre and post intervention was vertebral fractures, so the number of fractures that somebody had before or after the intervention. And importantly, these were often just self-reported, which is a limitation because we know a lot of those can be missed. The self-reported physical function did not show a change. Physical activity, cardiovascular endurance, and physical function also did not show a change after these multi-component programs that included spinal manual therapy.
So perhaps that shows that there are benefits, but let's say participating in physical therapy isn't necessarily a magic cure-all that can make everything better in the aging person with osteoporosis.
Yeah, exactly. It comes back to the multi-component program. So, physical therapy is really part of the larger picture. We're part of the puzzle as well. So not only the interventions that we do, but ourselves within the larger team as well.
One of the details in there that I think is worth highlighting is the fact that vertebral fractures were not increased as a result of treatment. And I think that speaks back to, first, the thing that I said earlier about how one of the questions I get asked a lot by my patients is, have you ever broken a bone while applying manual therapy? To me, that's not just a question about, hey, is this thing that you want to do to my body safe? It also speaks to the, let's call it the mental state or the concerns, the anxieties, the worries that patient might have. To me, that's very important because I think culturally we have caused people to have a lot of fear surrounding the existence or potential existence of osteoporosis. And one of the tidbits that I often give these folks is that older people or individuals with osteoporosis often fall. People of all ages fall. And it's not like every time they fall, they have 10 fractures. I love, for example, to tell a story about my grandmother from when she was in her mid-70s. Unfortunately, she slipped and fell down. I want to say it was about 4, 5, 6 stairs and landed in the corner of the concrete basement. And she was bruised and battered and, embarrassed, but she had zero fractures at all from that fall, which is, of course, unrefutable evidence that my grandma is the Terminator. But that's a separate conversation for a different day. But again, I think it speaks to the importance of understanding that, there are risk factors here. Yes, we need to be wise and targeted and careful. But just because someone has osteoporosis doesn't mean that they are instantly this fragile little being that is going to break apart and crumble.
Yeah, that's a really good point, and something that's really important when you're working clinically with somebody with osteoporosis. A lot of times people will come to me recently diagnosed and say, oh, I've been told, I can't golf anymore. I can't pick up my grandkids. I can't do all these things. And what's more important to me is not that they can't do these movements anymore. It's how do we, teach them to do these movements safely. So it's more about modifying them rather than completely eliminating them and saying, you must never bend forward, you must never pick up anything heavy, you may not go golfing ever. It's more putting it into a broader perspective of, how can we help you move safely through your life? How can we try to, prevent those falls? Or, if you do fall, how can we help you be able to get up off the ground or whatever it might be? So it's, again, part of a larger perspective rather than stop doing everything you ever liked to do, because then obviously that's going to have negative consequences on mental health and other health outcomes, like cardiovascular endurance and all those types of things.
I think that's very well said and super important. And one of the things that I like to teach my patients about is that there are different forms of osteoporosis. And as you so eloquently mentioned, one of them is associated with being a female and being older. But there's also a type of osteoporosis called disuse osteoporosis. And if the person is scared into thinking they can't move, they can't sustain any sort of weight-bearing resistance in their skeleton because it's dangerous, then they're also missing out on that healthy stimulation of bone, which helps the bone actually be healthy.
Exactly. It's a two-way relationship. So it's super important to get people moving and doing the things they like to do and just making sure they're doing it safely.
After having processed all of the information that was identified in the search, are you able to say how commonly adverse events happen when manual therapy is applied to people with osteoporosis?
So in the 4 clinical studies we found, there are very few adverse events reported. The ones that were reported were reports of pain during mobilization. There was a large randomized control trial that we included that had 181 participants who received grade 2 to 4 PA mobilization, so even higher than that grade 3 that we've kind of applied as a cutoff. And of those 181 participants, there were no associated adverse events. And the other 2 randomized control trials that we included, none of the reported manual therapy associated adverse events were serious, so they didn't require hospitalization or life-threatening illness. Essentially, they were pain during mobilization. What's really important, though, is that only the case study assessed vertebral fracture before and after the intervention. And many vertebral fractures don't come to clinical attention, as I mentioned, kind of in the epidemiological introduction. As many as 2/3 don't come to clinical attention. So it's really important that, moving forward, future studies that look at including manual therapy, they should really assess fractures via imaging during or after the intervention, because it's not necessarily super accurate to just rely on the participant reporting whether they've experienced a fracture or not, because they actually may not even know that it's happened. So that's a really important kind of future research step for any researchers out there listening. Before and after the intervention, fractures should really be assessed via imaging and not just relied upon through self-report.
That sounds like great advice to future researchers, and of course that would add to our overall knowledge on this topic. And as we're moving into the end of the interview, I'd just like to ask you if you were to sum up this topic and just give the practicing clinicians out there an overview of what they should be considering in terms of osteoporosis and manual therapy, what would that take-home message be?
The take-home message from this article is that PA mobilizations could be included as part of a multi-component physiotherapy program for people with osteoporosis. Of course, you want to think about why are you including those? What's the goal that you're trying to achieve with those mobilizations? So it's not that they should be or they need to be, they could be, depending on what your goal is. They may help improve pain, quality of life, thoracic kyphosis, balance, and upper back and arm endurance as part of that multi-component program. Really, our evidence in this area is limited and should be interpreted with caution until we have more evidence. But from what we know, you could consider including it as part of your program. If you are going to include it, we suggest that it shouldn't exceed higher than a grade 3, because we know that grade 2 to 3 mobilizations have been studied to date with no serious adverse events. And based on our biomechanical literature, the force produced by a therapist performing grade 3 mobilizations doesn't exceed that threshold where the vertebral components begin to fail. What's really important is that our suggestions don't apply to grade 5 mobilizations or manipulations, because those are different. They're high velocity, low amplitude, and that was not the purpose of our review. So didn't really answer that question with our work. But hopefully what you've also taken away from our talk today is that a thorough subjective assessment is really important to tease out those risk factors for somebody who might have osteoporosis and vertebral fractures and may not even know it. You may be the person who identifies it. So it's really important to do your screening questions. If you have some concerns, perhaps sending the person back to their physician or sending them for screening. A bone mineral density test would be really important, because they can get the appropriate treatment, whether it's medication, depending on their risk level, whether it's more physiotherapy with you, whether it's talking to a dietitian. So it's really important to identify those people who maybe don't know they have osteoporosis or maybe don't know they have a vertebral fracture. So really asking those important questions like, do they have a history of a low trauma fracture? So a fracture that happens from standing height or less of the hip, wrist, or spine. Have they been losing height? Are they taking medications that increase their risk for osteoporosis? Or are they on an osteoporosis medication and they're not sure of it? Or do they have other medical conditions that could lead to secondary osteoporosis, like cancer or malabsorptive disorders? And then if any of those kind of flag you, then making sure you send them back to their physician to receive the appropriate treatment.
Thank you for that summary. I think it's overall a great way to wrap up the conversation, and I think it hits on a lot of those key biopsychosocial components that we should all be aware of every day in clinical practice. So with that as a just spectacular ending, I want to thank you for being a guest on the podcast today. This has been a great conversation, and I think our audience is going to find it very useful.
Great. Thanks so much for having me. I had a great time talking about osteoporosis. It's my favorite topic.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.